In reviewing the VOYAGE 1 and VOYAGE 2 trials of guselkumab for psoriasis, this is an IL-23 blocker. It is dramatically effective for psoriasis, and it beats placebo, of course, by a lot, but it also beats adalimumab by a lot. So it's a very effective treatment, and that came through loud and clear in the trials. As you look at the results of the trial, it gradually improves psoriasis, but continues to improve it up through week 16, and that benefit persists for a long time thereafter. In the Ultima 1 and Ultima 2 trials, risankizumab was compared to ustekinumab, one of the most effective treatments we had over the past decade, and to placebo. And risankizumab was dramatically more effective than placebo, and also substantially more effective, significantly more effective than ustekinumab. So here again is an IL-23 blocker, which beats all of the comparators and reaches levels of improvement that we didn't have before this. The reSURFACE 1 and 2 studies looked at the comparison between tildrakizumab, a new IL-23 blocker, to etanercept and to placebo. And there were 2 doses of tildrakizumab that were studied. Both were superior substantially to placebo and to etanercept. In this study, in contrast to the other IL-23 studies, they probably picked too early an endpoint, because as you look at the studies, what you see happens is the patients treated with tildrakizumab continue to improve beyond week 12, and actually even beyond week 16, those patients continue to get better. But the primary endpoint that was selected was week 12. And that was probably an error, and it may have been an error because Merck, the company that ran the trials originally, did not have experience in psoriasis. And they selected week 12, which was an old endpoint for old therapies that worked perhaps more quickly, but at a time when studies were only being done, initial studies were only being done for 12 weeks. And nowadays, most of the drugs we test actually look out to 16 weeks. So tildrakizumab's package insert suffers from that. Had they looked 4 weeks later, they would have done a lot better. But in the reSURFACE 1 and 2 trials, still, the drug is dramatically more effective than placebo and then etanercept, and continues to work actually in subsequent trials for years. I have quite a number of patients on tildrakizumab, and they are uniformly happy. I've had almost no patients, I think only one patient actually stop using tildrakizumab of many that I have on the drug for lack of efficacy. The drug not only works well, but continues to work. And one of the benefits it has, as do the other IL-23s, is it's not given often. It's given 4 times a year. And so this is a drug that makes patients' lives as close to normal as possible. With only 4 shots a year, you basically go about your business the rest of your life. You don't have to give yourself injections every week or every 2 weeks or every month. And you don't even have to give yourself injections. They're administered in the doctor's office 4 times a year. So that is a big advantage of this therapy over others. One of the advantages that using IL-23 blockers that are administered in the office has over other treatments is an insurance advantage. In particularly patients on Medicare, where we can't use various companies' free drug programs or discounts or coupons, patients have to pay whatever the copay is. If the drug is administered through a pharmacy benefit, patients have to pay that pharmacy benefit. If they have Medicare Part D, there's a donut hole, which is usually a few $1,000s, at least $5,000. Patients have to pay that every year. Whereas if they get a drug that's administered in the doctor's office, it's part of their medical benefit so that they don't have to pay anything. It's administered in the doctor's office as long as they have a coinsurance that covers all of their visit. With many of the drugs that we use in patients who are obese, which is part of the metabolic syndrome, the drugs simply don't work as well. And we see that over and over again with most of the drugs that we use, actually. The data from the tildrakizumab studies shows a very minor impact of weight on the response to therapy, and specifically in patients with or without metabolic syndrome, they still respond very well to tildrakizumab.